December is a really... And please note this is being recorded. Thank you for coming down. I know December is a really busy month, and absolutely delighted to have two fantastic speakers with us today. But before I start, I'd like to start with an acknowledgement of country. So I'd like to acknowledge the Bidjigal people of the Eora Nation. Hi, welcome. Hello. They are the traditional custodians on the lands in which we're meeting today. I'd like to acknowledge elders past and present, and I'd also like to acknowledge the children who are our future leaders, and I'd like to extend that welcome to any Aboriginal and Torres Strait Islander people who are here with us today. I'm Paula Bray, and I'm the Director of Research for the Sydney Children's Hospitals Network, so it's a real pleasure to be here today. As I said, our last seminar, and it'd be remiss of me to speak without extending my heartfelt thanks to both Toby and Sam for coordinating our seminar series for this year. It's been really great to get everyone back in person this year, and hopefully we can build on this for next year and get lots of people back together again, because research is a team sport and definitely best played when we're all together. As I said, without further ado, we'll get going. I'd like to firstly welcome Suzanne Nevin. So Suzanne is a postdoctoral research fellow within the discipline of paediatrics and child health at the School of Clinical Medicine at UNSW Sydney. Dr. Nevin completed her Bachelor of Psychology and her PhD at UNSW. Her PhD focused on co-developing evidence-based positive psychology resources to improve psychosocial outcomes among families and children living with severe neurodevelopmental conditions. Dr. Nevin's research interests around advancing clinical practice in complex childhood illnesses, with a particular focus on co-developing patient-centred resources for families and children living with rare genetic conditions. I'm really excited to hear your presentation today, and welcome, Suzanne.
Thank you for the opportunity to present to you today about the research my team and I have conducted in partnership with families of children living with rare neurodevelopmental conditions. So the majority of my presentation today will focus on research examining the needs and perspectives of families, with a particular focus on a group of conditions known as genetic, developmental and epileptic encephalopathies. And if I have time at the end, I'll briefly introduce a new project we've recently embarked on, which explores another important piece of the puzzle, which is understanding and learning from clinicians' perspectives and co-developing a research agenda to provide tools to empower clinicians to optimally care for patient families living with rare neurodevelopmental conditions. So developmental and epileptic encephalopathies, which I will herein refer to as DEEs, are a group of life-threatening conditions characterized by early onset, treatment-resistant seizures, and premature mortality. And they also have devastating comorbidities that have a profound impact on children and families. Across the network, there are approximately 400 patients with a suspected or confirmed developmental epileptic encephalopathy who require extensive support from different departmental teams. With advancements in genomic sequencing technologies, a molecular diagnosis can now be achieved in up to 50% of children where a genetic diagnosis is suspected. However, these advancements have yet to translate into precision therapies for affected children, and the complexity of these rare conditions can introduce challenges for both clinicians and families. Now, our research is demonstrating that families experience immense distress, social isolation, and poor quality of life outcomes without a clear treatment pathway or a body of information to wrap around their child's condition. Our multidisciplinary team shares a collective interest in genetic DEEs, and the co-genes team is a team is a clinical research team whose vision is to understand how the emotional and psychosocial needs of families can be met in order to co-design tailored resources. So our research adopts a multi-pronged co-design framework targeting 3 primary pillars, including education and information, continued family engagement, and co-designing psychosocial supports. So over the next few slides, I'll briefly walk you through some of the individual research studies we've sequentially undertaken in partnership with families to understand their needs, as well as to identify the gaps in care. So the first step to kickstart our research involved a systematic review, which aim to address parents' needs for information and preferences for both content and style of information delivery. Results from the review highlighted the need for understandable, high quality, and reliable information about their child's genetic epilepsy diagnosis, as well as personalized information on how to navigate their child's condition. Now, the review also highlighted the families needed information to access psychological supports, psychological supports and as well as emotional supports. A second finding from the systematic review was that parents' needs for information differed during different stages of their child's diagnostic journey. So, for example, surrounding the diagnostic period, families prioritized the need for expert information from trusted clinicians as well as lay resources focused on their child's genetic epilepsy diagnosis. By contrast, 5 years post-diagnosis, informational priorities shifted to the need for updated information to align with their child's neurodevelopmental comorbidities, as well as behaviour and care management plans. So this really highlighted for us the need to keep parents updated with current and stage-specific materials relevant to their child's condition progression and across the care continuum. Findings from the systematic review provided an initial evidence base to inform the development of updated genetic epilepsy resources, carefully defined and refined by the coaching team to support communication between families and clinicians outside the specialist healthcare setting. And these resources are openly available and accessible online on our Pediatric Epilepsy New South Wales website. So the second step of our research involved engaging with parents in our local community networks to conduct in-depth interviews to get a deeper insight and to understand parents' psychosocial experiences, as well as the impacts of undergoing genetic testing and their information and support needs before, during, and after their child's genetic testing and diagnosis. We also included validated measures to assess parents' satisfaction with genetic testing services, as well as the impact of genetic testing on quality of life outcomes. So our thematic analysis helped to identify priority areas for psychosocial supports, which included the need for supportive genetic counselling, particularly for families faced with a suspected genetic diagnosis in the acute care setting. Parents also reported communication challenges with limited prognostic information about their child's diagnosis, which over time contributed to physical and emotional burnout. On the other hand, companionship support, as well as compassionate support from healthcare professionals, was associated with more positive emotional adaptation to their child's genetic diagnosis. And a recurring theme was the mental health difficulties families were experiencing in isolation, as well as the consistent difficulties they faced accessing psychological supports that matched onto their family needs and understood their circumstances. So the combined results of both of these studies highlighted the need to develop accessible and appropriate psychological supports for families. Now, given that there's limited guidelines on research targeting rare disease families, we invited families to participate in co-design workshops, which aimed to understand how we could develop resources that effectively and appropriately supported their needs. Parents' feedback revealed that hearing other parents' stories normalized their emotional experiences and reduced their sense of isolation. They also prioritized the need for practical, cognitive, and evidence-based strategies to help them to cope during different stages of their child's diagnostic journey. We then continued to engage with families to prioritize themes from both the interviews that we could use to inform the development of a suite of psychological resources. The 6 key themes or domains that parents prioritized that mapped onto their journeys included shock, isolation, struggle, looking forward, finding strength, and attaining hope. So the workshops really helped us to realize that the concept of positive psychology was a valuable framework to develop meaningful and scientifically informed resources for families. With continued input from our research as well as family engagement, we developed 6 positive psychology resources that we have now called Finding a Way. Each video is approximately 5 minutes in duration and narrated by our team psychiatrist, Professor Kenneth Nunn. The resources and videos include quotes from families as well as lived experience stories from parents that help them to emotionally cope. And they also include cognitive strategies designed to mobilize parents during different stages of grief. So I'm conscious of time, but I will just briefly play you a short clip of one of the videos to give you an insight into what they look like.
the sort of hope that gets us through. How will we live the life in which we find ourselves? What sort of attitude do we need to face the world, our future, and ourselves, that will get us through the tough times and still leave us able to enjoy the good times? For much of our lives, we don't have to stare reality in the face, and it doesn't force us like a mirror to stare back, to look at ourselves and whether we are up to facing the problems we are facing. But sometimes we do have to stare reality in the face, and the problems are too big, too difficult, and threaten those we love too much.
So the benefits of positive psychology resources have been shown in other populations, but we were aware that psychological resources specifically co-designed with families of a child with a genetic DE were lacking. So before making these resources available online, we invited parents to participate in an evaluation to assess the acceptability, relevance, and emotional impact of the resources. And we also included qualitative questions to scope what families liked about the resources, as well as what suggestions they had to improve the videos. We are also grateful that several rare disease collaborative groups kindly shared a study flyer using their social media platforms, which then allowed us to recruit families from outside our network and even internationally. With their support, we had a total of 167 parents from over 18 countries engaging with our resources and our online evaluation. Overall, parents reported that the content was understandable, relevant, and that they would have found the resources helpful when their child was first undergoing genetic testing. Parents were also highly satisfied with the resources and reported that they provided helpful suggestions about seeking and accepting help from others, as well as the shared experience of caregiving and managing their personal and social relationships. Frequently reported emotional responses after reviewing the resources included feeling comforted, hopeful, connected, and reassured. And this was important for us because we set out to develop resources that would promote emotional sharing and a sense of connectedness amongst isolated families. So as one parent noted, "They were beautiful. I'm literally in tears as I write this. I wish I had access to something similar 4 years ago when we got our child's diagnosis, but I'm grateful for them today. They are still just as relevant today as they would have been back then." Families also provided valuable recommendations, including the need to normalize help seeking for the shared challenges that families faced, as well as the need to increase access to non-clinical psychological supports for parents' mental health and well-being. Families highlighted the need to also educate and to train clinicians on how to support families experiencing ongoing isolation, grief, and uncertainty, particularly for those families facing additional challenges that often emerge during the later stages of their child's diagnosis. So I've included here a quote from another parent. "I found myself very alone, very afraid, and very distraught in the beginning, and I still feel the same to some extent. There's still very little focus on helping the families cope. I find the advice in the videos very helpful and approachable." So in keeping with these recommendations, we have made the resources openly accessible using our hospital endorsed PEN website again. And I've included the link here in case you're interested in checking them out. And now that the resources are live, we are fortunate to have received some small seed funding to run an implementation trial to investigate the feasibility of incorporating the resources into clinical practice to broaden the reach and impact. So using the RE-AIM framework, we conducted 3 in-depth workshops with interdisciplinary clinicians, both rural and outreach healthcare settings. And we really set out to investigate the barriers and facilitators to delivering and offering psychological supports to families. The key take-homes from our study currently are that the resources improve understanding of families' emotional experiences and enhance open communication with clinicians. Clinicians also report feeling more confident to use the resources as they have been co-designed by families, and also that they provide a tool to support communication about seeking psychological support for those families who are more reticent. Not surprisingly, our research, however, has emphasized that the demand for psychological supports exceeds availability. and highlighted the need for integrated psychological supports for families as part of multidisciplinary care. So that brings me to the close of our current research with families of children with developmental and epileptic encephalopathies. However, beyond this work, we are also expanding our psychosocial research into other rare neurodevelopmental conditions to develop support for families for other families. An example of this is our Childhood Dementia Insight project, which we are conducting in partnership with the Childhood Dementia Initiative. So childhood dementias are a group of devastating neurodegenerative diseases characterized by global neurocognitive decline after a period of normal development. While there are currently over 70 genetic conditions known to cause childhood dementias, up until now, these conditions have been researched individually in silos, with the focus being on the underlying causes instead of how these conditions collectively present and impact children and families. So our research involves a world-first project to investigate and address these conditions under the umbrella term of childhood dementia, to allow evidence to be better translated into clinical practice and psychosocial supports. So our Childhood Dementia Insight project has adopted a similar framework to with the first step of the project involving a systematic review to collate the international evidence focusing on the shared psychosocial impacts. So we have identified several key overarching themes arising from 19 studies which stem from 11 different countries, representing the perspectives of 1,838 parents. Our results emphasize that childhood dementias are associated with extensive economic, social, and psychological challenges owing to the rare, life-threatening, and progressive nature of these conditions. Parents also experience cumulative stresses as well as chronic sorrow due to a widespread lack of clinical expertise to care for children with dementia. And our study also highlighted opportunities to enhance coordinating psychosocial supports surrounding the various diagnostic periods, as well as the transitionary phases in the child's healthcare trajectory, as well as offering earlier access to palliative care services surrounding the advanced stages of the illness. So the next stage of our research involves an in-depth mixed method study with parents and health professionals to develop a deeper understanding of Australian families' unmet psychosocial, quality of life, and mental health support needs, as well as clinician knowledge gaps providing family-centered care. So in addition to our in-depth qualitative interviews, we will be including an evaluation to quantify the social, emotional, behavioural, economic, and relationship issues impacts, as well as assessing the proportion of bereaved and non-bereaved parents who meet DSM criteria for mental health conditions, including prolonged grief disorder. And in doing this research, our goal is to really listen to the voices of families and to conduct translational studies that can inform healthcare and psychosocial tools to optimise quality of life outcomes for families and children. We've just received ethics approval for the mixed method study, so I look forward to sharing the data that comes from this study with you soon. And I think I don't think I have time to go into the last bit of the study, but I do? Okay. So this brings me to just the final step of the project, which I'll just reiterate is in its early days of development just at the moment. So this project really aims to investigate interdisciplinary clinicians' experiences and perspective providing complex care in order to develop tools to enhance their clinical practice and psychological well-being. So I'm sure the audience here will appreciate that clinicians who care for patients with complex and severe neurodevelopmental conditions can experience a difficult caregiving remit, which often involves balancing multiple competing clinical and psychosocial components. The rapidity of gene discovery and publication across both medical and lay resources can also make the process of providing families with relevant information and support exceptionally difficult. So over time, what we are finding is a deficit of tailored resources can lead to compassion fatigue and burnout. So here's a quote from one of our clinician participants, which just exemplifies one component of the emotional challenges. There's a risk of burnout and compassion fatigue because it can be relentless. It's not a subspeciality where you actually fix anybody, but you think a lot of the junior guys find quite confronting. It's living with the fact that you're describing the difficulties, but you're not necessarily fixing anything, and the grief, loss, and distress of the families. So our clinical project aims to engage interdisciplinary clinicians utilising an empirical framework and a multi-phase research design to understand their needs and to co-develop a novel toolkit intervention tailored to empower clinicians by promoting reflective thinking on key topics of purpose, meaning, and making a difference. So we've engaged interdisciplinary clinicians from across the network to participate in our research as members of our co-designed advisory board. And while the research is still in its early days, just to give you a snapshot overview, we have conducted 25 in-depth clinician interviews, as well as 14 interdisciplinary reflective practice workshops to promote and to stimulate shared understanding, as well as to identify research priorities. And we have also been working with our advisory team to develop a resource toolkit, which at the moment includes a compilation of simulation videos, podcasts, and group reflective practice guides surrounding themes that clinicians have identified as important. And going forward in 2024, we do intend to evaluate the resources to understand if they're helpful to a broader network of clinicians and to understand if the resources lessen feelings of isolation and to promote a sense of improved reflective insight and well-being. I hope this presentation has given you a small flavour of some of our research, and I thank you again for your time.
So I wondered if there's any questions while everyone's thinking. And for those of you on Zoom, please do pop any questions into the chat.
Fantastic work.
Oh, yeah. Thank you.
So again, congratulations on the work. It's really fantastic. Curious to know what your sense is of what common and specific elements there might be across clinical conditions in terms of the psychosocial need and what interventions or resources can be put in place.
Thank you for the question. I think across both those studies and other genetic psychosocial studies, we are finding three primary, I guess, gaps in psychosocial services. One being the diagnostic period, the second being maybe 1 year post-diagnosis, and then towards the advanced stages of the condition. So I guess it's hard to say. Every family's experience is subjective and different, but there is a strong need to improve psychosocial supports along the continuum of care.
Thanks.
Easy.
Again, I congratulate you on a really lovely body of work. I'm interested in the difference between families where you end up with, say, a label and a genetic diagnosis versus those where you don't. Do you see that there are any differences in the needs of those families where you end up with a formal diagnosis as opposed to where you have a child who's got an undiagnosed but similarly severe condition? You know, the information and the psychosocial needs for those families different or same in any way?
That's a really good question, and one that I've always come back to. I think families who receive a diagnosis are often quite relieved initially, and then they can often kind of almost become disappointed after a while of realizing there isn't much supports for their child's diagnosis. So I think what's really important is connecting families to other families who have a similar diagnosis, be that undiagnosed or diagnosed, and making sure that they feel supported, because families have amazing resilience and strength once they find their feet and feel comfortable that they are appropriately supported and know where to go if they have issues down the line.
Oh,
I was going to say, from a familiar face in the lunchroom to actually understanding what you do, it's fantastic. And I think you have to be recommended for the steps that you take into implementing well and co-designing well. So congratulations. I'm really keen to know what you've done in regards to families with language and cultural differences and, you know, the resources. And apologies if I've missed it, but just trying to understand a lot of what you've presented. It seems to be for the English, those that understand English. So what have you done for the other families that may have these children?
And that is a theme that plays on our on our, I guess, consciences quite a lot, because the funding that we've received has just been for English-speaking families, and we haven't had the capacity to extend our research to those non-English speaking families or CALD families at present, although it is something that we really would love to do going forward. It's also a topic and theme that came out of our implementation trial, was that the families who don't speak English or are struggling the most and that really need psychological supports and connectivity are those CALD families. So that came directly from our clinicians, as well as the families themselves. Again, some of the families who spoke English but weren't from Australia had demonstrated a lot of resilience if they felt connected, and there was a lot of more positive outcomes that came from families who had strong faiths, which I think just again speaks to the resilience of families and the different coping mechanisms people can adopt. But I think going forward, it would be so wonderful if we could have these resources translated to be co-designed specifically and tailored for families from CALD families. Thank you.
Thanks, Suzanne. So our next speaker is Dr. Joanna Fardell. Joanna is a Senior Research Fellow at the Sphere Cancer Clinical Academic Group, working in the Living Better with and after cancer area of focus. She's also Deputy Director of Australia's largest psycho-oncology research groups, Behavioural Sciences Unit, part of the Kids Cancer Centre at Sydney Children's Hospital. Dr. Fardell also holds a clinical appointment as neuropsychologist for the Western Sydney Youth Cancer Service Crown Princess Mary Cancer Centre at Westmead Hospital. I'm almost there, Jo. And Jo's research interests focus on improving quality of life of people of all ages impacted by cancer, particularly through improving cognitive, social cognitive, and education and work outcomes, addressing unmet information needs and fear of cancer recurrence. Jo has experience in quantitative, qualitative, and mixed method research methodologies. And that's a really important bit, because for people looking to collaborate, it's wonderful to know what your interests are. So welcome, Jo, and please join me in welcoming.
Thank you. Wow, I feel really lucky to be presenting on the last seminar of the year. So thank you very much for the invitation. I'm known to waffle, so just, speed me up if I look like I'm going down that path. So I thought what I'd start with is sort of a conversation topic in terms of what is quality of life and what does it mean to you? I'm really happy to take answers from the audience. Just shout them out to me. Don't be shy. What makes you happy? Comfort. Yeah. Anything else? Yeah. Awesome.
Meeting grant submission.
Meeting grant submission dates. Yeah, winning that grant. This morning I was very anxious about giving this talk because I'm feeling a little bit rusty in terms of giving public speaking engagements. And I asked my 6-year-old daughter on the way to dropping her off to school, I said, darling, what makes you happy in life? And so according to my 6-year-old daughter, Grace, it's custard or desserts. And I said, that's great. That's really important. Tell me what else is really important to you and what makes you happy in life. And in rapid fire succession, she listed Mummy, Daddy, Edward, her brother, our dog Hercules, who's a cavoodle, not a big dog. And then she quickly listed off school, acro, which is her dancing class, and gardening. And so this is Grace's definition of quality of life. But if we look at the definition of quality of life according to the World Health Organization, surprisingly or unsurprisingly, the things that Grace told me really line up with the domains that have been highlighted in numerous studies. This particular citation is from 1998, but I guess in terms of thematic and systematic reviews that have occurred subsequent to then, quality of life is largely thought to consist of key domains around physical functioning, psychological or emotional functioning, social functioning, which can be replaced with role functioning in some models, and the environment, the impact of the environment. And when we talk about health-related quality of life, what we're really interested in is the way that health can intersect between a person's perception of their overall well-being in each of those domains. So why should we care about quality of life in cancer care? Well, pleasingly, overall survival for many childhood cancers and adolescent cancers is over 90%. But there is a real treatment burden, and this is common across all cancers and all treatment modalities. There are treatment toxicities and side effects. There's a management burden. Parents and families need to front up for appointments. They need to coordinate medication, and they need to know how to care for their child and turn up to emergency if it's needed. There are also persisting and enduring late effects and impacts on family wellbeing, including psychological health, finances, and career. And often these burdens are underreported by patients in clinical encounters. And there's a number of reasons that have been put forward in the literature for underreporting in clinical encounters. I'm happy to talk about that on another occasion. In this context, I've had the great pleasure and privilege of collaborating with Toby for many years. I think we started in 2016 on the ASSET study, which is a large national registry of treatment-related toxicities for children diagnosed with acute leukemia, lymphoblastic leukemia, sorry. And I'd really like to just quickly focus right now on the impact of therapy on children's health-related quality of life through the first year of treatment to set the scene in terms of thinking about impacts on quality of life. So this study, which was really led by Clarissa Shilstra and Karen McCleary, two really wonderful PhD students whom I've had the privilege of supervising, looked at quality of life over that first year of treatment and also looked at toxicities. Now, in our health-related quality of life sub-study, we had 25 toxicities reported across the sample by 26% of the sample. And most of the toxicities in that first year were neurotoxicity, and most were grade 3. And you can see here in terms of the distribution of the sample. But what I want to focus on now in terms of the quality of life outcomes is what you can see here in this panel is that along the x-axis, T1 to T12 represent the first 12 months, so T1 being month 1, T12 being month 12. Quality of life generally improves across time, which is really fantastic. And if we look at the y-axis, what that means is 0 is worst possible health and 1 is best possible health. And any decrements down from 1 are considered not perfect health. Even though we've got these really wonderful improvements and we see that, you know, average scores are starting to push up to perfect health or perfect quality of life, when we look at a minimally clinically important difference, approximately 60% of our families are reporting quality of life below population norms. So let's tease this apart. What does that mean? Why is this overall measure showing an improvement over time, but we've still got these clinically significant and clinically important differences to population? If we look at quite specific aspects of quality of life, so those domains of quality of life, we have these measures within paediatrics, which I'm sure many of you are familiar with, but the PEDS-QL has a cancer-specific quality of life measure. And what you can see here is the number of domains that are assessed throughout treatment. And across that first year of treatment, procedural anxiety remains a significant contributor to overall quality of life, as does aspects of nausea. So that's that orange, I don't think the cursor works, but the orange bar through here. No, you can't see my cursor. Okay. Continue to impact quality of life through that first year. If we look at parent emotional wellbeing, which is we know an important driver of child quality of life, the reciprocal relationship between parent and child is pretty well established. We assessed emotional wellbeing using the emotion thermometers, which has a recommended cutoff at 4 for significant or clinically meaningful distress or anxiety or depression or anger, sorry. And what you can see is that whilst parent emotional well-being improves again over the 12 months, there are some, I guess, emotional domains that remain elevated, and that is distress and anxiety well into the first 9 months of treatment. What was really great about this particular study is that we had the opportunity to flag concerns. So just up on this particular measure, we have this need for help. And so for parents who indicated that they had a need for help, and it was combined with a high distress thermometer score, so above 4, we were able to look at what the requests for help were. So we had a proportion of parents, 17 or 20%, requested help once, and 3 parents requested help twice. And we were able to address their help needs through predominantly through information provision. So through access to supportive resources that are publicly available, or to flag their concerns with their treating team. The great thing about this study when we set it up was that for any instances of distress that were identified and flagged as needing help, we could then communicate with the treating team and get that additional support to that family as needed. So if we look at quality of life beyond treatment, what does that look like? So we've looked at that first 12 months and we can see that there are impacts across that first 12 months. And in this publication of 182 survivors of childhood cancer, these are all under the age of 16. Their average age at the time of completing the survey, the parent proxy report on children, was 12 years of age, and they were approximately 10 years post-diagnosis, and you can see the makeup of the sample there. What we found is that quality of life across a number of domains as measured by the Kids Screen 10 was generally pretty good, except for feeling sad and feeling lonely. And I think this really resonates with some of the work that Suze was just presenting in terms of that isolation and wanting to feel connected to families with similar experiences, or feeling that peer or community connection to bolster psychological well-being. The other thing that we found that was quite interesting is that the treatment received and the experience of late effects, so in those years after treatment had finished, really contributed to quality of life. But other factors in this sample didn't contribute to quality of life. When we drilled into a closer examination on the feeling sad and feeling lonely piece, what we did find is that if parents were reporting low quality of life themselves and low resilience, they were more likely to report difficulties with their child's quality of life. And we can speculate around those interrelated, outcomes in that population. If we use qualitative research to delve into this a little bit deeper, in a sample of 49 parents of children with chronic health conditions, a range of different ones, some fabulous work led by one of my ILP students a number of years ago really highlighted some of the themes that came out in terms of quality of life impacts. And the 3 key themes that her work really highlighted was that physical impacts can lead to missed opportunities to socialise. Being different due to an illness can have significant impacts on peer relationships and emotional well-being. And thirdly, that emotional and social skills development can be impacted through missed opportunities. Some further work done by Clarissa looked into the incidence or the experience of social anxiety symptoms. And so in a sample of 27 adolescent and young adult cancer survivors who had had cancer as a child, 33% had reported clinically significant social anxiety symptoms. And Clarissa has really gone on to develop a really wonderful body of work focusing on social anxiety and social outcomes and how we can best support young people through cancer. She's very, very recently had some clinical guidelines published on how to support social outcomes of adolescents and young adults with cancer. And I see that as an important next step in this piece of understanding social aspects of quality of life. So where to next? I guess in terms of thinking about where the interface between research and clinical care exists, one of the key things that I often come back to is the notion of quality of survival being equivalent to the quality of life that's experienced through and beyond treatment. And so really a key goal of anyone doing research in this space or delivering clinical care is to try and maintain quality of life as much as possible. And I think that would probably resonate with the audience quite highly. I've been very privileged for the last 10 years to work at the Behavioural Sciences Unit and have seen a number of really fabulous interventions developed around improving domains of quality of life. And I'm just highlighting a few here. I know that this is a little bit out of date. We actually have a lot more going on in terms of a really large research group. But the next step, for me, in terms of this research are really to consider patient-reported outcomes. And so in 2009, the FDA put out a statement regarding patient-reported outcomes and what they are. And they were then at that time, and still are, now included in labelling claims and clinical trials as a primary, and can be included as a primary outcome measure. And so according to the FDA, a patient-reported outcome is any report of the status of a patient's health condition that comes directly from the patient without interpretation of the patient's response by a clinician or anyone else. So patient-reported outcomes really are those that matter most to patients and families, and they assess treatment benefit and harm beyond survival. So while we aspire to improve outcomes in terms of duration of life, patient-reported outcomes are really about the quality of life. So cure at what cost? So why might we measure patient-reported outcomes? Well, I think some of the research that I've shown so far really highlights the nature and power of aggregate data. So we're able to chart a course. We know that on treatment, quality of life generally improves over time, but that there are lasting impacts in various domains of quality of life, most notably in terms of psychosocial, emotional, and social functioning. But when we look at a clinical setting, can we consider using patient-reported outcomes in a routine, standardised way to improve clinical care? And I think we can. It's a systematised way of assessing outcomes that matter to patients and families. And whilst we might do this in a clinical setting in a routine way, we may not do it in a systematised way. And this is one way of doing it. And so I'm really pleased that we were very lucky to receive a seed grant from Sphere, or Maridulu Budjari Gumar. And this is I'm really pleased to be leading this body of work called Kids Voice. And the goal of this is really to, through having conducted some scoping and some literature reviews, we're now at the point of doing a lot of co-design and co-creation. So we're working with both consumers, so that's young people and families, as well as clinicians, to co-design what using patient-reported outcome measures looks like in clinical care and how to respond to them. We're then hoping to conduct an implementation feasibility and pilot test of this model of care. And this is really a work in progress. We've literally just started, so watch this space. And I'd like to wrap up with a final plug to another initiative that I've been lucky enough to be part of. And this is the Luminous Alliance Psychosocial Enabling Platform. And I guess this is a call for any clinician researchers out there who feel that they would like some support. Please reach out through this enabling platform. We're really hoping to build capacity among clinical and research teams across the Sydney Children's Health Network to deliver world-class research and clinical care that intersects, that prioritise psychosocial outcomes, as well as considers the lens of equity and diversity, and so building up expertise and capacity in those particular domains. So on that note, I'd like to finish, and thank you for giving me this opportunity. I hope I didn't waffle too much, but happy to take questions.
So again, fantastic work there. Just wondering if you're connecting at all with ICHOM, so the International Consortium for Health Outcome Measures. So there's a series of patient-reported outcome measures, international consensus. So for child and adolescent psychiatry, there's a whole bunch that we use within New South Wales that are mandated, and then there's this international set that are consensus-driven. Curious to know if that connects with this work.
Yeah, well, I haven't connected with ICHOM specifically, more with EORTC QLQ group, like the quality of life group in terms of European groups. But noting that there is a lot of movement in this space internationally in terms of developing models of care, but certainly an avenue to pursue. And I think to your point in terms of, you know, a set of recommended measures, I guess at the ground level, what I've been finding when I've been talking to clinical teams is that there are commonalities in terms of the concerns that they might have in terms of what symptoms or burdens they might like to measure, but there's also just quite distinct needs that need to be captured. And so having a suite or a set of measures is really valuable in this context. Thanks for the suggestion, Ian.
Thanks. Thanks for a great talk, Jo. I was just wondering, is there quality of life measures, or have you compared with other conditions that are more, I guess, regressive in nature, even in the PED space? And have you compared findings from, say, cancers, that there's a higher recovery rate or survival rate, and how those quality of life measures differ in different respects, both between patients and families?
Yeah. Really important question. A lot of the measures that have been produced today, like everybody has their own measure. I think academics love creating them, they love distributing, they love validating them. What has been really interesting is that the interpretation of those patient-reported outcome measures has been lagging. So whilst we all have disease-specific measures and there are commonalities, like they all map onto the models of quality of life that are out there, when you do systematic reviews of measures, vastly there are no clinical cutoff guides or interpretation guides. So, for example, the Huey, which I presented, has a score of 0 to 1. What does 1 mean? What does 0 mean? And as a clinician, if I give that to my family in front of me, when do I act? Do I act when it's 3, or do I act when it's 7? What's the point that I act at? So some of the nuance I think that is starting to emerge is, what are those clinical cutoffs for particular populations? And that work can be done at large scale, so with really, really large quantitative studies, or it can be done at small scale in terms of talking to families and figuring out what their, I guess, maximum level of burden or minimum level of action that they require in different settings. And there's different methodologies that are being employed there, and we're hoping to do something similar here with the oncology cohort.
Thank you.
Thanks, Jo. That was really fantastic. And as you know, very close to my heart. So a couple of questions. One is just probably extending on that. How close are we in terms of sensitivity to change in quality of life? And it's sort of an ongoing kind of narrative. And you sort of touched on some of the methods we can use to start to, I guess, get a better handle on it. So obviously looking at clinical thresholds is one thing, but are we actually certain that a change from 1 to 2 is the same as a change from 2 to 3? So what are your thoughts about just how we're getting closer to sensitivity and specificity?
Oh, good question. And I'm a measure development person at heart, so I don't think we're there. What I do see when I look at the research around instances where models of care using patient-reported outcomes have been used is that the power tends to be in the longitudinal shift and the response to it. So even though we've got measures which are showing a drop, it's the clinician who's looking at the score and going, hang on, there's something wrong here. I really need to see you face to face. And that I feel we're still trying to figure that out, if that makes sense. I don't know if I've given you a good answer, but that's my read on it.
Yeah, absolutely. And if I can ask one more, just touching on response shift. How much, again, noting some of your graphs over time, how much do you ever do any adjustments, like statistical adjustments to accommodate for response shift or those raw data?
Yeah, they don't adjust for response shift. So good question. And I think like all of Borowski's work really, he's a theoretical guy in quality of life, if you're a bit of a nerd like me. He talks about that change of internal locus in control. And I think an improvement in quality of life, our data shows that overall improvement reflects a level of adjustment and a level of acceptability, and at the point at which you're comparing your current functioning to your best possible functioning shifts. But the fact that those individual domains remain low, for me, is the real tell. So overall, there's an adjustment, but there are still domains and impacts that are concerning and bothersome and burdensome that could be addressed in a sense in terms of intervention.
So, Jo, great work. Do you think the tools that we've got now will remain fit for purpose going forward? And the reason why I ask that is that, you know, with the advent of immunotherapy, particularly in adult oncology, they talk about life-altering side effects. You know, you get autoimmune thyroid damage or something like that. And there's sort of a range of side effects we don't necessarily see so much with conventional therapy. And so I suppose the question's really around how do we make sure that the tools that we've got remain relevant as therapy changes a lot as well?
Absolutely. So I sort of presented the overview of quality of life. The conceptualization of how we get to overall quality of life suggests that the proximal symptoms, those things which might change, are really important. So that symptom burden then feeds into the functional burden at that quality of life level. And my gut feeling is that whilst we might have a shift in symptoms and particular types of symptoms, and our measures will need to adapt and keep up with that, the overall functional impacts will remain fairly constant. People want to remain as a parent or as a school child engaging in school. They want to be able to be physically competent, however that looks for them, and they want to be psychologically well or emotionally healthy. So I think those aspects probably won't shift, but I'm just guessing here entirely. Oh, okay. Wow.
So Chelsea Online just says, thanks so much, Joanna. Will we clinicians, researchers be able to access the Kids Voice resource that you mentioned once the pilot is underway?
Absolutely. Contact me. Yes, please. And definitely looking beyond the scope of this grant to scoping out what it looks like more broadly for other clinical settings and making sure that, I guess, you can future-proof the work in a general sense. Thank you.
Am I allowed one more question?
Oh, okay.
So given some of the challenges we have in proxy reporting and quality of life, what age do you think kids can self-report? And I'm asking because obviously I loved the way you opened with your 6-year-old. What age can kids reliably report their own quality of life?
Oh, such a good question. So the literature says from 8 years and above, but I feel like if you talk to any parent and their 3-year-old tells you that they are in pain, my gosh, you are believing them, aren't you? So I think we probably need to land on developmentally appropriate domains for reporting, knowing what we know about how language develops, how memory develops, and how concepts of understanding time. So, for the classic example is that a 3-year-old will tell you that they have a sore need, but that actually happened 4 weeks ago because they haven't got the same ability to temporally tag what's happened in the last week. So I think for under 8, we need to land on what is sort of like the signal or sentinel domains of quality of life. And I would argue feeling sad and pain are probably, you know, they're 2 areas that I would hazard some guess on. Anyway, there are other more qualified developmental psychiatrists in the room.
Excellent. Well, that concludes our seminar series for 2023, and please do come back and join us. The seminars will be recommencing in February 2024. I would like to wish you all a fantastic holiday and festive season, and I hope you get time with your loved ones, time to rest and recover. And I'm really excited to come back in 2024 and keep advancing towards our ambition of truly becoming a research-intensive organisation. So thank you all and have a great holiday, please. Thank you.